I would like to thank you for being here in person or online. So we'll speak about the evaluation of the endometriotic patients by ultrasound in combination with modified ancient classification. Ultrasound is the first-line imaging tool in gynecology and, of course, in patients with known or suspected endometriosis. And due to training programs and especially due to the advancements, technological advancements, ultrasound performed by experienced operator as well as the MRI performed by experienced operator reliably detect pelvic endometriosis. And currently we accept that expert ultrasound and MRI are highly useful alternatives to laparoscopy. In accordance with 2022 guidelines of the European Society of Human Reproduction and Embryology, laparoscopy is no longer considered the diagnostic gold standard. It's now recommended in patients with negative imaging results or where the treatment, empirical treatment, is unsuccessful or inappropriate. For meaningful comparison between the studies, for unambiguous communication between the healthcare professionals, sonologists, gynecologists, general surgeons, urologists, or others involved in the field and working with endometriotic patients, and of course, for appropriate orientation and counseling of our patients, we have to speak the same language. We should use standard lexicon, standardized assessment techniques. Then we should appropriately classify the findings using standardized classification system, and also it's very important appropriate to present the information, to transmit our information using appropriate standardized protocols and reporting forms. So this presentation serves, and I would like to provide a modest contribution to the standardized, comprehensive and systematic ultrasound assessment and reporting of endometriosis in pelvic structures in combination with the modified ancient classification. So when we speak in the first place about standardized lexicon and assessment, we know very well that IDEA made very important step forward. We have the consensus paper, we can consult it, and we can find their recommended terms, definitions, and measurements. And in accordance with IDEA group, dynamic ultrasound assessment includes 4 steps. The order is not mandatory. The first step is the routine assessment of the uterus and adnexa. The second step is evaluation of indirect signs, soft markers, size-specific tenderness and ovarian mobility. The third step is assessment of the porch of Douglas using ultrasound-based real-time sliding sign. And the fourth step is assessment of posterior and anterior, or anterior and posterior compartments for deep infiltrative lesions. Different studies we have in the moment. We also could heard during this congress and see the results. But for this session, I select this one from Daniela Fisherova's group. It's a not validation study of IDEA protocol due to relatively reduced number of the observations, but this is a very good proof of the concept. In accordance with the results of this study, when experienced operator use IDEA protocol, then ultrasound has the same accuracy as MRI in the detection of deep endometriotic lesions in the upper rectum, in rectal sigmoid and ureter, while in other pelvic structures it is associated with marginally higher specificity but lower sensitivity. No overall negative impact on the detection of pelvic endometriosis deep lesions were observed. The second Classification. Over the past 4-5 decades, more than 20 different classification, staging, and reporting systems have been proposed. However, in 2022, we do not have the agreement, international wide agreement, which one is the best one to be used. In 2003, ENSIAN was developed to improve the description of deep endometriotic lesions, initially for the surgery. And in 2021, the classification was extended and modified, and newly modified ENSIAN classification now includes also the peritoneal lesion, the ovarian lesion, and the conditions affecting tubo-ovarian units. And something that's extremely important, we can use ENSIAN for both non-invasive and surgical procedures. So for assessment of the patient by ultrasound, by MRI, and by laparoscopy, the same system. In accordance with the ENSIAN, we use letters to code different structures or regions, and then for each region or structure we use number 1, 2, or 3 to express the extent of the pathology. So P is used for the peritoneal lesions, O for superficial ovarian lesions and endometriomas, T for conditions affecting tubo-ovarian unit, namely adhesions that may interfere with mobility and tubal patency. Then in the posterior compartment, we have 3 A, B, and C subcompartments. The A subcompartment is the vertical one. So rectovaginal space, posterior vaginal fornix, Douglas, and retrocervical region. Then B is the lateral subregion. We have there uterosacral ligaments, cardinal ligaments, and pelvic side wall. And then C is reserved for the rectum and rectal lesions. Then FA we use for adenomyosis. F is used for further lesions. FB, bladder, FU, urethra, F, and then in parentheses, diaphragma, for example, for diaphragmatic lesion, and so on. Few studies demonstrate that there is a high degree of concordance between imaging-based and surgically based classification when ENSIAN was used. And based on the here you can see the list of the studies. Based on these studies, we can see that in combination with ENSIAN, ultrasound reliably described deep endometriosis, ovarian endometriosis adhesion, but its accuracy is it's less accurate for B compartment, for parametrial lesions. Based on these studies and data, a series of international, national, European, national organizations recognize ENSIAN as a valid and suitable tool. But in parallel with standard language, standard technique to assess the patient and appropriate classification, standard reporting is very important. Clear, comprehensive, and well structured. There are scientific data indicating that structured in comparison with narrative reporting improve surgical planning and probably improve the surgical outcomes. But we have proof that in complex diseases such as cancer, such as endometriosis, structured reporting apparently is better than narrative reporting. And the International Society of Gynecologic Endoscopy, through to different cycles of paper assessment, paper analysis, study analysis, and expert discussion, the society and the task force for the endometriosis developed a proposal, a structured report template for dynamic ultrasonography in patients with known or suspected endometriosis, and in combination with modified ENSIAN classification from 2021. And now let's see practically what we'll get if we join IDEA, ENSIAN, and the standard reporting by ISG. We used to perform scan after collecting data, anamnestic data from our patients and after physical observation, and we start reporting our general impression. We think it's appropriate to start reporting by expressing our general impression, confirming or denying the existence of the frozen pelvis. Of course, frozen pelvis can be caused by endometriosis, or it can be caused by other pathologies such as infection. Then we used to map the disease to explain the symptoms, to orient the patient. We start mapping the disease from anterior to middle to posterior compartments. In Portugal, at least, many times we start with the middle compartment, then assess the anterior and the posterior. As far as it's organized and well structured, I think it's irrelevant starting on one side or on the other, but anatomically it's logical to start from anterior. And in the anterior compartment, it's included uterovesical region that we can check using the sliding sign. It can be non-obliterated or obliterated. In most cases, it's obliterated due to cesarean section, not to endometriotic lesions. Then the anterior compartment assessment includes assessment of urinary bladder, that can be normal or abnormal, and abnormalities are coded in accordance with ANSI and with FB code. And then ureters, that can be also normal, as on this video, or abnormal. And when we observe abnormalities, we code the lesion by ANSI and FU code. Don't forget to pay attention always to the kidneys and to the existence of hydronephrosis. So whenever we observe a lesion, we should measure in 3 orthogonal planes, and after that we should provide surgically relevant information. And if you observe, for example, the lesion like this one, the bladder region, okay, we have to provide information of its exact localization, whether it's which bladder region, whether it's trigon, base, dome, extra-abdominal part. Then the distance, information of the distance of the lesion, distance between the lesion and distal ureter orifice. And also it's very important that we understand if the detrusor muscle is infiltrated only, and that there are also urothelium invasion. And for all lesions that we can touch by probe, it's also very important to understand whether the lesion is associated with symptoms or not. So tenderness, pain, if it exists or not. In the middle compartment, we assess, of course, uterus and adnexa. We use Musa suggested terms, definitions, and measurements to describe the myometrium and myometrial pathology, and we use IETA terms, definitions, and measurements to describe endometrial lesions, endometrium and endometrial lesions. Of course, the particular attention will be paid to the signs of adenomyosis, and if you observe the signs of adenomyosis, that can be direct and indirect, and of course that we pay of course much more attention, and we are more sure with diagnosis if we observe direct signs, then we will code this situation by ANSI and FA codes. For the adnexa, we use, of course, IOTA terms, definitions, and measurements. To assess the risk of malignancy, we use IOTA tools, namely the adnex model. And if we observe endometriomas, we would measure that and code the situation by ANSI and O. By definition, the first we code on the left side and then the right side. And for example, if you observe 2 endometriomas like on this image, we are going to sum the largest diameter of these images. And something very important, adhesions, conditions that affect tubo-ovarian units, we code these situations by T code, and I'll show you example how we used to do. So we observed a patient with dysmenorrhea, with dyspareunia, and I would like to start this video. Is it possible to play this video? Yeah, we'll need just a second. Okay, I tell you the story, the clinical background. Yeah, you can help me. That's not my computer. So, okay, 32 years old nulliparous woman with severe dysmenorrhea and dyspareunia. We observed uterus, and it was yeah, that's good, fantastic. And we observe the direct signs of adenomyosis, and then we evaluate the first the left ovary. And what would you say? There is sliding, apparently no adhesions between the left ovary and the uterus, right? And then on the other side, I mean on the same side, but now we analyze the relation between the ovary and the pelvic side wall. What would you say? I consider that it's slightly reduced. So I would code that as T1 on the left side, and on the right side, I think no doubt there is adhesion between the ovary and the cervix and the uterus, and also adhesion between the ovary and the pelvic wall. Even we can see the pushing of the iliac vessel, you know. So I would code that as T2. There were no. Look, the intestine. What do you think? Is there any adhesions between the ovary and the bowel? I don't believe so. It wouldn't be T3, but I would call that as T2 situation. Okay, on the right side, we also observe the endometrioma, typical unilocular ground glass formation. So, and also the women presented the signs of adenomyosis. So, after the assessment of the central compartment, I would say this is O01 T12 FA situation. And finally, posterior compartment. This is the most frequent site of endometriotic lesions. As I previously said, we have 3 subcompartments: the A, including rectovaginal space, vaginal fornix, rectocervical area, and Douglas. Then lateral B subcompartment, uterosacral ligaments, cardinal ligaments, and pelvic side wall. And finally, rectum. Each side can be normal or abnormal. If abnormal, we will measure all the lesions and provide surgically relevant information. So I will present only one lesion. This is a case of a woman with a rectal lesion. So we should measure and then provide surgically relevant information, including its exact localization, whether is it lower or upper rectum, then distance of the lesion, if there are more than one lesion, this distance of the most caudal lesion from the between the lesion and the anal verge. Then we should provide information on the percentage of the bowel circumference involved, deepest bowel layer infiltrated, and also information whether significant luminal narrowing exists or not. This is a woman with cyclic rectal bleeding and with severe dysmenorrhea and dyspareunia. And you can see the Douglas. Always when we have a liquid fluid in the Douglas, it helps. I think that we agree that there are adhesions between the bowel, ovary, that's retrouterine, and the uterus. And in the assessment of the A subcompartment, you can see this is the vaginal fornix, cervix in front of the probe, vaginal fornix, and the vaginal fornix we observe this lesion. You can see the movie. This lesion here, I would say that the lesion is in contact, but probably not infiltrating the bowel. The B compartment, you can see here, there were some adhesions, but I would consider I couldn't see the lesions in the uterosacral ligaments. But scanning the intestine, we observed that huge lesion, obvious, probably infiltration of mucosa, and we would code that as A2 lesion and C3 lesion, rectal lesion more than 3 centimeter. So if we observe the lesions above the rectum, we would use the same approach, the same methodology, and for the other sides, such as diaphragm, such as umbilicus, we should specify by localization, local lesion size and morphology, the alteration. So something also that's very, very important, a big advantage of ultrasound in comparison with MRI, in comparison with surgery. We can speak with the patient. We can understand if there are sites, even without lesions, that are painful, or lesions that are not significantly painful. So we used to finish, to summarize our report by NCN code. Even if you don't speak very well the language, even if you don't understand the report, just looking to the NCN codes, you can see, for example, in this patient, you can see that she has, just looking the code, you can imagine the pelvis. You can see it here that the patient has an endometrioma on the left side, that the tube is not permeable of the left side due to important adhesions between the bowel, uterus and pelvic wall. On the other side, we have some adhesions between pelvic wall and the ovary, and but tubal function is preserved, and also that the patient has lesions in B and C units. So, to summarize, mapping of pelvic endometriosis by ultrasound is accurate when trained sonographers perform the technique. Structured reporting of the lesion may improve the patient counseling, organization of multidisciplinary teams, and selection of the most appropriate medical and or surgical therapeutical strategies. And the ISG structured report template for dynamic ultrasonography in combination with NCN classification is available. Thank you.